Okay, fine. Right. So, welcome to Good Physio Community Webinar Series. Monthly, once or twice, we must provide a free webinar for our students and young physiotherapists. So, this is the main aim is to introduce myself. So, what I'm doing and what all the things I can able to do through the webinar. And one more thing is, I want to teach freely about the anatomy, biomechanics, pathomechanics through my webinar each and every month.
ரெக்கார்டு
தம்பி நீங்க பேசுறது எல்லாம் ரெக்கார்ட் ஆகுது. மியூட் பண்ணிட்டு பேசுங்க. ரைட், ஆரம்பமே அமக்கலமா இருக்கு. ஸோ நவ் லெட்ஸ் டைவ் இன்டு த டாபிக். So before that, what is meant by good physio community? So good physio community I started 1 year before, June 2024. So initially I started giving free lectures or small paid lecture for my known students. After that, I started as a good physio community. So my aim is to make a good physios. Actually, there are good physios. Already we are all good physios only. The thing is, we are not finding the good physio within us. So I hope everybody should start the search in us to find a good physio. Then you can able to be a good physio. So for that, what you need to do, first you need to learn. Whatever you are learning from this webinar or from your lectures or wherever, you need to practice that through your patient, or you can practice through your colleagues or somebody who are needing the physiotherapy. And with that, you'll get some expertise. Once you get the expertise, I want you to lead your community, your local community, or whatever you want to lead a physio community to help others. And also you should lead the peoples who are suffering with pain and dysfunctions. You are going to help them. Okay. I wish you all the best for that. So this is myself. I don't want to push myself to waste that time at all. I am Dr. Sharad Kumar. I am a sports physiotherapist. Right. Now, I already told my vision also. So the main vision is I want to provide a quality content through my webinar. Thereby, I want to make a good physiotherapist within you. That's it. I want to just find the good physiotherapist within you. Sharing, caring, growing together is our mantra of success. Whatever you know, you share. So whatever the people who are helping and who are coming to you to get a knowledge or to get some kind of help through the physiotherapy, you just care them. And it like growing together. So whoever is like nearby you, your juniors or somebody, you give your hand and lift them also. Okay. Then we can able to get the success. Now, kindly follow the instructions. So I gave you everybody the access to unmute yourself by yourself. You can able to speak in any time during the webinar. If I'm giving some power means you should use that power with full responsibility. Okay. So if you don't know that you are like unmute or something, so don't do kind of disturbance. It won't disturbance me itself. It will disturb the entire people and the content also will get disturbed. So be responsible, my dear students. I hope you will be responsible. Now, so what is the main aim for me to conduct this webinar? This is the syllabus. So today what we are going to see is only a superficial anatomy, biomechanics of the myofascial system, followed by the pathomechanics of the trigger point. That's it. That is the first day. And this is completely free. And the paid thing is I want to introduce the biomechanics of the and integrated functions of the myofascial system. There are a lot of myofascial systems are there. Superficial, front line, deep front line, superficial back line, deep back line, oblique system, lateral system, superficial front arm line, deep front arm line, superficial back arm line, deep back arm line, back arm line. So these are all the different kind of systems which will mimic like a reticulopathy symptom or some other symptoms. And yes, and we are going to identify those systems in detail. Followed by that, we are going to see the evidence-based treatment in current practice, 2025 I'm telling. In current practice, what are the evidence-based treatment to treat the trigger points and what are the literature support for that. Okay, and among that, Like if you have a manual therapy, in that you have a mobilizations, you have a myofascial release, you have a dry needling, you have an instrument assisted soft tissue mobilization, you have a cupping therapy, you have a taping. There are a lot of a number of techniques are there. We are going to see each and everything, what is the effect on the trigger point, and with that, which is evidence-based treatment for the appropriate treatment for the trigger point. That is the thing we are going to see. So with that, I'm going to show some videos also, okay, to how to assess the trigger point, how to find out the trigger point. Okay, these are all the things we are going to see in the paid class. That's it. And for the paid class, usually my webinar used to be like a 500 per person, but today I'm going to unlock the offer for you, and that will be too much friendly for the students. Especially I made it like for the student only, so that I will open in between the webinar. Okay, right, this is the main goal, one of the main goal of my webinar. At the same time, whatever the content I'm giving, I won't hide anything. Whatever I'm telling, it will be fully transparent. You can have the guarantee from me that for that. Yeah, now we can go to the webinar. So this is the special guest. What I am going to give is cervical IVDP mechanics and pathomechanics. So I'm going to give that 1.5 hour, I think so nearly, that recording. It will be there for you for next 1 week to 2 weeks. Within that, you need to watch and finish. After that, that link will get disappear automatically. Okay, that you are going to get freely. So this is only for the finishers. So be patient and listen completely. So before going to the topic, what are the myth about the trigger point? Usually, people are think like trigger points are not like it is there like originally. It is like a mental stress knots. Or else some people used to tell if you do exercises directly, we can come out of the trigger point. So we need not to do trigger point release. Maybe student, kindly mute yourself, Dr. Malavika. Like that. So, but the research shows that neuromuscular junction dysfunction. So, trigger point is like a neuromuscular junction dysfunction with excessive acetylcholine and local ischemia is the one of the reason to get the trigger points. Okay, they found it in 2022. So, who found it? Simons. Yeah. Now, stretching alone can eliminate trigger point. So, a lot of people used to tell if you do stretching, you will come out of the muscle release. If you go to any Insta, if you go to any social media platform, if you have pain here, do these 4 exercises. If you have pain here, do these 3 exercises. Like that, they used to attract the patient. But the real myth, that is the real myth. So, stretch helps, but energy crisis, there is a concept called energy crisis, which is behind the trigger points, and end plate dysfunction, it should be addressed, okay, and it should be treated properly. So then only we can able to come out of that trigger point. So stretching alone can't eliminate that. And pain from trigger point is random. They used to tell like that. It is not like that. They proved that Simon and Travel, they proved that it is like a predictable pattern. Depends on one muscle, we can able to identify uh, it may be how it is like whether it will refer laterally or else it will refer medially, anteriorly, posteriorly. Depends on the muscle. We can able to guess it. Okay, so it is not like guessing. So they proved through the specimens they did the uh, researchers. Okay, so these are all the myth and the scientific evidence behind the trigger point. Instead of that, if you have any doubt, I will give you 10 seconds. You can ask me. So within the 10 seconds, who are all asking a question, I will give you the scientific answer for the trigger point. So any myth, if you have anything like want to ask, you can ask me. Any question? Feel free to ask the questions. I'm always here to help you. Okay, I'm going to the next slide then. Now, so I can understand your situation that first you want to know what I'm going to tell. Okay. With that, you may have some question in future. So I will give you the extra time in further slidings. So in that, if you have a doubt, you can ask me, no problem. Right. So usually what we imagine in our mind is like this only. Usually muscles will be like a straight line with that there is a small bulge and taut bond that is called it as trigger point, right? This is the scenario usually which will run in the brain if you imagine that. So come to the introduction to the myofascial system. So this is myofascial system dysfunction. Okay. So what is meant by myofascial system? Myofascial system is a 3D network. That means fascia is a connective tissue. Muscle is a muscle tissue. Fascia is a skeleton for the muscle. You have a separate skeleton called bones, but the fascia is like a skeleton for the muscle. If the fascia is not there, each and every muscle fiber will get collapse and it can't able to organize by themselves. Okay, if one sarcomere need to attach with another sarcomere, it must need a muscle fiber, it must need a fascia. Okay, I hope everybody knows the Z line. Z line used to be there in the sarcomere between the one sarcomere and another sarcomere. ZZ band disc. Okay, so that disc is a connective tissue. Okay, there are a lot of proteins which will anchor the myosin filament. Okay, so those are all a fascia. And if you know, there is a covering layer of the muscles, epimysium, perimysium, endomysium. These are all the facial structures. These are all not the muscular structure. So what you should understand now is fascia is not a covering layer of the muscle. Fascia is the in and out. Okay, in and out. Each and every muscle fiber in the muscles is connected through the fascia only. Okay, so fascia is the structure. Through that only you are having the whatever the blood vessels, whatever the nerve, okay, it need to reach the fascia and it need to reach the muscle. So everything it is connected. So fascia is not just a passive covering. It's not like a passive covering also. It is a continuous three-dimensional connective tissue network. Okay, that's why they are telling three-dimensional. That envelopes, interprets, okay, it not only envelopes means coverings, interpenetrates actually, okay, it penetrates, interpenetrates and interconnects muscles, it will connect between one muscle fiber to another muscle fiber and altogether it will connect the muscle to the bone through the tendon. Tendon also a fascia only. It is like a connective tissue and it is having a specialized cells called tenocytes. That's why it is a different from fascia alone. Okay, but that too also a connective tissue only. It is a modified fascia, that's it. And bone. In bone, there is a layer called periosteum. I hope you already know. That periosteum layer is the especially where the tendon is going to merge. That's it. Nerve, blood vessels also they are telling. Okay, it is not only for the muscles, it is for the blood vessel and also for the nerves. So keep in your mind. It consists of what it consists. It is a connective tissue, hence it is a connective tissue. It consists of elastins, collagen. Okay, collagen gives the structural stability. Elastin gives the deformity. Okay, deformity in the sense deformable structure. Whatever the load you are giving, whatever the tensile force or compressive force, it can able to adapt it. Its behavior depends on that. Okay, elastic in nature and creating both stiffness as well as elasticity. What I told already. Okay, transmitting the tension, especially transmitting the tension. And model anatomical dissections, they told that fascia links different body segments into functional chains, meaning no muscle active isolation. So this is the very much important point. There is no muscle in the body which act on isolation. If you take a hamstring muscle, it have a connection with the ligament called sacrotuberous ligament. That sacrotuberous ligament is having the connection with the erector spinae. Okay, if you come down, that hamstring muscle is having the connection with the gastrocnemius muscle. So through that facial systems, it is working as a facial chain from the head to the toe. So that is the thing we are going to see in depth in the pain with that. Yeah. Now, these are all the evidence. Fascia is an active sensory and proprioceptive organ. It is a sensory and proprioceptive organ. They are telling it is not like a passive only providing a structural stability. Not a passive structure. They demonstrated that fascia is innervated with nociceptor. So, if the fascia is getting stuck, you will have a pain. So on mechanoceptors, so fascia can able to sense the pressure, fascia can able to sense the touch sensation, everything. Just a second. Just one second. Yes. Yes. Sorry for the disturbance. Now, so the fascia is innervated by the nociceptors as well as the mechanoceptors. Thereby, it can able to sense the pain, pressure, whatever the stretch, whatever the thing you are giving, it can able to sense. Now, in 2018, some author found there is a increased hyaluronic acid viscosity in dysfunctional fascia contributing to stiffness and pain. What is meant by hyaluronic acid? Hyaluronic acid is a natural acid which is secreted from our body, usually which is secreted by the synovial layer of the joint capsule. Okay, joint capsule synovial layer is there, right? That is the inner layer of the joint capsule. So that secretes the hyaluronic acid, which is necessary for the joint mechanisms to happen smoothly. So that hyaluronic acid, it is also okay influencing the stiffness and pain in the one who is having a dysfunction in the fascia. So they found in the dissection. They are telling that fascia has rich sympathetic innervation, linking it to stress-related muscle tension and chronic pain. So these are all the things you should understand that why the patient, whoever having a more stress and the muscles also is getting tight. This is the reason. It is having a rich sympathetic innervation. Thereby, if you are tense, if you are having an angry, your muscles will go automatically. Whatever the postural muscles, whatever the muscles which is usually go for tightness, it will go over tightness. So that's why cognitive behavior therapy came. Okay, I hope you understand this point. Let's go to the core concepts of the trigger point mechanics. So what is the core concepts of the trigger point mechanics? So let's break one by one. Trigger points arise from the integrated hypothesis. So this hypothesis of neuromuscular dysfunction, actually this is called a neuromuscular dysfunction. You can say the trigger point is otherwise known as neuromuscular dysfunction. Neuromuscular junctional dysfunction. There is a junction between the nerve and the muscle, that is called neuromuscular junction, which is having the dysfunction for some reason. Because of that, you are getting the trigger point. I will going to give you the idea of in depth, okay, in the following sessions. So who is the person Travel and Simons in 1942? She is a physician actually, and she did the research and she found the word, she coined the word trigger point initially in 1942 itself. That is the hyperirritable nodule, and it formed because of the uh, ischemia in the particular tissue. That means less in the blood flow, and also there is a taut band kind of structure which is there and which is restricting the range of the muscle, everything. And followed by there are a lot of dissections and histology studies, and they found what all the exact thing which is happening behind the trigger point. So we'll see that one by one with recent evidence. Now, mechanical overload. You are getting some mechanical overload. I will let you know what is that. With that, the muscle is going for a sustained contraction. With that, the acetylcholine is getting excessive in production without resorption. With that, the muscle is going for a continuous depolarization. Because of the continuous depolarization of the muscle is like a Depolarization means what? Muscle is contracting. If the muscle is continuously contracting, whatever the blood vessels, whichever blood capillaries, whichever there in the particular muscle, which is compressed by that muscle fibers and which is going for the ischemia. That means there is no further blood supply for the muscle. Because of there is no further blood supply for the muscle, there is a process which is happening that is called energy crisis. I will let you know what is that. Because of the energy crisis, your muscle is not getting relaxed. So failure to relax. Okay. It is failure to relax. Because of it is failure to relax, finally you are end up with the trigger point formation. Each step is interconnected. Okay. I'm going to let you know everything, and finally you are sensing the pain. That is also I'm going to explain. Yeah, this is found in the 2021. So Shaw et al. Who found. So, and this is especially what he mentioned is the end plate dysfunction. Now, come to the point by point. This is that neuromuscular junction. If you see, this is the motor neuron. Okay, this is the axonal terminal, and this is the postsynaptic neuron. That means this is the muscle fiber. So this is the outer layer, that is the sarcolemma of the muscle fiber. And if there is any impulses which is coming from the nerve, okay, that is the action potential we used to tell, right? Action potential when it reaches. So what will happen? Action potential related calcium channels will open, that will go and rupture the synaptic vesicles. Because of the rupture of the synaptic vesicles, acetylcholine will release from the presynaptic neuron. That acetylcholine go and bind with the postsynaptic neuron, that is the muscle fiber which is located in the muscle fiber. Then that acetylcholine go and bind with the receptor. Because of the binding of the acetylcholine, there is a gate will open in the muscle fiber. That gate is called ligand gated channel. With that opening of the ligand gated channel, what you will have? You will have a more entry of the sodium ions. Okay, so sodium ions, actually it will be there inside usually, so it will come out. So there is a more negativity will happen, that is called depolarization. So because of the depolarization, what will happen? So your action potential will get developed uh, through to the muscles action. Okay, to the muscles, and that action potential will make the calcium channels in the from the outer surface of the muscles, it will go into the especially the what is the exact uh, machineries, that is the sarcomere. That center in the calcium will travel. I will let you know everything one by one with the image. See now, so whatever you are seeing there, it is the microscopic structure of the muscle fiber. Right. See here. This is the muscle part. Okay, this is the skeletal muscle. So I'm zooming the skeletal muscle here. So when I zoom the skeletal muscle, first what I am taking is I cutted the muscle. Once I cutted the muscle, there is a separate layer called fascicles. Okay, I'm just taking the one fascicle. That one fascicle, I am again zooming it. So once I zoom it, there are a lot of bundles of the structures which is arranged in the like cylindrical way, circular way. With that, only one I am taking. That is called a single muscle fiber. Okay. First, you are cutting the muscle, you are getting the fascicle, and you are cutting the fascicle, you are getting the muscle fiber. So if you take the muscle fiber one, this is the entire muscle fiber. In that also you are getting a lot of circular things. If you take only one, so that is called myofibril. So this myofibril is the actual machinery for the muscle contraction. Now you take only one myofibril and you take that and into the zoom, then you can find the Z line. Okay, this is the connective tissue, this is the connective tissue, and this is the I band. That is the actin filament, and this is the myosin filament. Okay, so this is the actin filament and this is the myosin filament. So here you can see the myosin head. You can able to see here. You can able to see the head here, here and all. So this head will get bind with the actin filament and towards the center of the muscle fiber. From the left side, it will pull towards the right side. From the right side, it will pull toward the left side, and together it will pull both side of the actin filament. Thereby, the distance between two Z line will get reduced. That is called it as muscle contraction. That is the sliding filament theory. So till now, everybody got clear? Is there any doubt? You can ask me. Now I'll let you know the neuromuscular junction again. If you are clear, you just type a C in the chat box. That means clear. So my dear students, kindly interact with me.
Clear, sir.
Thank you, thank you, thank you so much. Okay. Now you see here. So this is the entire muscle fiber part. This is entire muscle fiber. Okay. With that, there are some machineries that is called myofibril. Now you see the endoplasmic reticulum. Endoplasmic reticulum for the muscle is known as sarcoplasmic reticulum. What is meant by sarcoplasmic reticulum? Actually, there is some structure. Okay. So usually if you take any cell, outer layer is called it a cell membrane. Inner nucleus will be there. All the part inside the cell membrane used to call it as endoplasm. For the muscle, it is like a sarcoplasm. In that sarcoplasm, there is some structure called sarcoplasmic reticulum. What is that structure? That is the extra machinery circle. Extra machinery means machinery is the myofibril. If you go out of the myofibril, you can able to see there is a structure called mitochondria, which is giving you the energy. Okay, that is the with the oxygen it will produce the ATP. Like that, there is a sarcoplasmic reticulum. With that, there is a yellow color tube is there. Okay, this is called transverse tubule. Okay, that is the transverse tubule. So, and there are some blue color tube also is there. That is called longitudinal tubule. So, transverse tubes, transverse tube is the T tube, longitudinal tube is the L tube. And this transverse tube, if you see, this can able to make a hole. See here, there is a hole here, right? There is a hole. You can able to see. These are all the holes. What does this exactly mean? Whatever the action potential which got developed in the postsynaptic neuron, okay, it will pass through that hole only. It won't reach entire muscle fiber. Okay, that electrical signals will come through only the transverse tubule. Once it reaches this part, okay, this is called a terminal cisternae. Once it reaches this part, then what will happen? Here you have a pre-storage of the calcium ions. You have a pre-storage of the calcium ions. Once you reach that voltage, there is a opening of the voltage related channels for the calcium will get opened. So once the current got reached here, the calcium ions from the extra machinery place, it will go to the machinery place, and there is a structure called a troponin in the actin. Okay, in the troponin there is a structure called troponin C. Okay, so once it goes and attaches to that, there is a structure called tropomyosin, okay, which will come out of the binding site. And once it comes out of the binding site will get activate, and you will get the sliding mechanism. So that's how the muscle is getting contracts. So each and everything I can able to explain in depth, but here I can able to tell you in the superficial only. With the paid webinar, I can show you little more zoomed image. Thereby you can able to imagine better more things. Okay. So that is the thing. So because of that, and with some ATP and everything, you will get a contraction in the myosin head, and your contraction will happen. This is the orientation of the contraction, how it is happening. Now there is a dysfunction going to be happen. Because of that, you are going to get a trigger point formation. We will see that. Now, mechanical overload, I told you. What is that mechanical overload? Everybody is telling mechanical overload. What is meant by that mechanical overload? Mechanical trauma or repetitive overload alters the sarcomeus integrity. That means what is the meaning is, um, if you are holding a certain position for a long time, awkwardly. So why awkwardly? Why not with proper posture? Yes, if you adapt a proper posture for a long time also, if you are crossing your limit of endurance, everybody will have some endurance in the muscle. If we are crossing that limit of endurance, what will happen? The muscle can't able to relax properly. If the muscle can't able to relax properly, then what will happen? That muscle can't get the oxygen and the ATP properly. So that muscle not going to relax. So that state ultimately will fall into the trigger point. Trigger point in the sense that it will go to the stage where it can't able to relax by its own, because we are the one we forced it to work uh, again and again without giving any rest. Because of that, what is happening? That muscle fiber went for tightening, okay, without taking the rest. Because of that, whatever the blood vessel. So if you have a pipe within your hand paw, your hand is the muscle. You have a pipe which is very much thin in the layer, very gentle. If you compress the pipe, okay, by means of your muscle contraction, what will happen? The blood circulation will go or not? It won't go, right? If you are contracting the muscle like that only, then you will go to the state called ischemia. With that ischemia, what will happen? There is no oxygen supply and there is no ATP supply for the muscle. ATP is must not only for contraction of the muscle and also for the relaxation of the muscle. Okay, you should remember this. So without the ATP and without the particular oxygen, you can't able to relax. This is one thing, one way of understanding what is meant by sustained or repetitive overload. Or else, if you do a sudden overload also, you will get what will you will get? You will get a muscle spasm. Muscle spasm is nothing but a protective muscle contraction followed by any high velocity movement or high intensity movement. If you lift anything more than your normal capacity, or else if you do anything fast or something, when you get up from bed or something, what will happen? Because of the overstretch or because of the over intensity, the muscle fibers goes to the failure stage where the muscle fiber will get a micro tear. Because of the micro tear, the sensation which is sensed by the intrafascial fibers of the muscle spindle and goes to the spinal cord, and immediate result will come to the muscle and arrest that muscle, thereby further damage won't happen. That's why the muscle is getting locked. So you can't move because of the muscle spasm. That is the reflex contraction of the muscles. Okay, got it? So this is the muscle spasm and this is the repetitive overload or sustained. Because of that is what is happening actually. What exactly is happening? That is the thing we are going to see. Now I will let you know everything one by one. So muscle fiber fail to return to the resting length, producing localized contracture. Overload also sensitizes muscle spindle afferents and increasing tone. I will let you know. I will let you know everything. Now, why you are getting sustained muscle contraction? Just a second. The first scenario is you are adapting voluntarily. Okay, I am taking webinar. I am making my upper trapezius muscle, my levator scapulae muscle, my erector spinae muscle in the neck to work continuously to maintain my head posture. This is the thing I am doing, okay, consciously for my muscles. I am not giving rest. A person who is going for a long drive, 500 kilometer is the target. He is not at all giving the rest after 250 kilometer or so. So he is consciously making the muscle to contract continuously. And one more scenario is some sudden movement or some high velocity, high intensity action. Followed by that, a reflex contraction is happening for next 1 or 3 days. One from 1 day to 3 days. Depends on the severity. It is happening because of the reflex contraction. Because then only the muscle will get inflamed, the muscle will get heal by itself. So this is happened by means of the body itself. Okay, we did something, so body gave the reflex contraction. Here we are the culprit, we are giving the contractions. So both are what is mean by a continuous contraction which is lasting more than the normal level. Because of that, what is happening? First, whatever the presynaptic, I told you, right? Presynaptic action potential which is coming to the presynaptic neuron, because of that acetylcholine is releasing. Now we are giving a more than 45 minutes, more than 1 hour, 2 hour continuously same position, especially software company people also, if you see, they used to work continuously. For them, what is happening? Continuously the acetylcholine is producing. That acetylcholine can't able to reuptake because you are not maintaining a you are maintaining an intermittent rest. So continuously acetylcholine is producing excessive in amount. Because of that, there is no proper reuptake of acetylcholine by means of a acetylcholine esterase. So that is the first thing it is happening. Okay, that is the first thing is happening. Second thing, because of increased secretion of the acetylcholine, there is a excessive depolarization of the T-tube, you know, right? T-tube. Because of the excessive depolarization, there is an excessive amount of the calcium ions which is going to the myofibril of the muscle fiber. Because of the excessive production of the calcium ion which is continuous, okay, through the myofibril. So my dear students, I am going to give you the I'm going to take out the access for you to unmute by yourself. So this is why, because I don't want to disturb others. Because a lot of people are unmuting themselves and doing some things without knowing themselves. See, this is the thing. Because of one person, the entire class will get disturbed. Unmute themselves can't happen from now. Yeah. I will give you the time where you can unmute yourself. Yes. So because of the continuous production of the calcium ion in the myofibril, what is happening? The muscle fiber is the tropomyosin got completely came out from the binding site. Now continuous contraction of the myosin head with the actin filament. So continuous production of the muscle contraction is happening. Because of the continuous contraction of the muscle, there is no further blood supply to the particular muscle, because there is no space to supply the blood. There is no space, right? Muscle is already occupied the space by means of the contraction. All the capillaries which are present inside that myofibril got compressed. It can't able to enter even. Because of that, there is a state called energy crisis. That means ischemia. That's it. Energy crisis. I don't have further ATP to relax my muscles. I don't have a further ATP or oxygen to relax my muscle. Muscle is begging for the ATP, but it not getting because the muscle is already tightened. Okay, you need to give an intermittent rest. Some people used to feel, I think so, if you continuously ride your bike, you'll get a chemical acid kind of thing, irritation, some kind of pain, aching while doing the activity itself. That is the stage you are, the muscle is begging for the ATP. What you need to do, you need to off the bike and you need to go for intermittent rest at least. You need to do something to come out of that position, then only your muscle will get the little bit of energy, and that will make you to work for another 15 minutes or 20 minutes. Okay. So after that energy crisis, the muscle ischemia. So the muscle can't able to relax by itself. So whether it is continuously contracting, there is a metabolic waste product. You have a lactate, okay, which is producing in the muscle. That is the one thing. That lactate is decreasing. Okay, that lactate is decreasing the pH level of the muscle. So with that, the muscle is getting a more painful. Now the muscle is going for the inflammatory stage. So because the muscle is not able to survive properly, it is going for the damaged state. The muscle fiber is getting damaged. So because of that, there is an inflammation which is going to happen there. So inflammatory mediators, your prostaglandins, your bradykinin, or hydrogen ions, whichever, okay, it is going to stay there. Because of that irritant, by means of that inflammatory mediator which is present in the muscle fiber, you are getting the irritation in the nociceptors, that is the free nerve endings which are present in the particular myofibril, and that is sensed by the muscle by the brain as a pain. So this is the entire pathomechanism behind the trigger point therapy. No, sorry, not the therapy, trigger points. So protective response from the alpha motor neurons keeps contraction active. This is followed by the uh, uh, muscle spasm. Usually this is followed by the muscle spasm. Intrafusal muscle fibers is the spindle, increased sensitivity, maintaining the tone. Sustained contraction compresses the blood vessel, I already told, so reducing in the perfusion. Now, excessive acetylcholine release, I told you, right? Trigger points linked to dysregulated neuromuscular junction activity. Excessive acetylcholine release, persistent depolarization of the sarcomere. Persistently, it is getting depolarized. That means the current is passing. Reduced activity of the acetylcholine esterase. There is an enzyme called acetylcholine esterase, which is present in the junction between the nerve and the muscle, which need to take the acetylcholine back. Okay, if it is not taking properly, then it will happen. That is because of the continuous contraction. So usually what is meant by motor end plate? So this is known as motor end plate. What is meant by motor end plate? This is the part of the muscle where it have the connection with the motor neuron. So that is called it as motor end plate. Motor end plate consists of acetylcholine receptor. Okay, thereby the acetylcholine ions will acetylcholine that which get binded with the receptor which is present in the postsynaptic neuron. Okay, that is the motor end plate. Through that, the sodium influx will happen. With that, depolarization will begin. So you need to understand what is meant by motor end plate. Sorry, unfortunately, I got cold today. Yes. Whether this is so I want to show you that what will be there in the 6-month membership program. So this is the masterclass physio webinar I created. This is for 6 months. So where you will get a 12 webinars. So each webinars will consist of a 3 days class. With that, first day I'm going to detailedly explain about the anatomy, biomechanics, pathomechanics of the particular relevant structural thing. Followed by that, so in second class, I will give you the deep insight of the evidence-based assessment for the particular condition. Then followed by that, you will get a treatment in the third class. That is also the evidence-based protocol. With that, cervical IVDP core, you will have a lateral epicondylitis, you have a sacroiliac joint dysfunction, you have a kinetic chain dysfunction in the lower limb injuries. Usually, if you have a ACL, a lot of people need to focus on the knee alone. Okay, they don't know how to integrate with the hip, ankle, and also the core. So I will let you know everything. Ankle sprain, why it is getting chronic ankle sprain. So how to prevent the recurrence, how to bring back the proprioceptive function of the ankle. ACL rehabilitation, I want to let you know everything together, like all to top to bottom. ACL is the common thing. So with that, we should be the master in that. Okay. So that's why I separately found that. And there are a lot of persons, people are there in the physiotherapy field, postural correction, postural correction. There is nothing like a postural correction. It is like a myth, but there is a postural correction, modern way it is there. That is the scientifically proven method I'm going to show in that webinar. TFCC injury, if you think your wrist, you should think your shoulder. Okay. So that means whatever the wrist is having the problem, how you need to find out the root cause from the shoulder, scapulothoracic joint. So everything I'm going to show that. And followed by that, knee osteoarthritis rehab. Usually osteoarthritis, we don't know beyond some exercises. We will be thinking that some kind of activation exercise of the VMO and followed by the hip abduction exercise and followed by some strengthening exercise of the knee muscles will help the people to come out of the arthritis. It is not like that. We should understand what is the cartilage, what is the healing capacity of the cartilage, how we can load the cartilage without overloading it optimally. And with that, we can able to go ahead with some evidence-based test. Then with that, we can frame the protocol effectively to make the patient to come out of the arthritis or to delay the surgery. So practically, we are going to do that. So that is the thing I'm going to show you. I want to teach you. And exercise prescription, this is the general thing. So whenever we have prescribed the exercise, we are telling the patient to do the exercise regularly, morning, evening, like that. We are stressing the patient. But there is a principle called uh, like fit principle. With that, there is a frequency. Strengthening exercise, how many days you need to do, how many repetition you need to do, how many sets you need to do, endurance exercise, like that flexibility exercise, like that stability exercise, like that power related exercise. Each and every exercise, how volume you need to give, how often you need to do. There is a protocol. We should know the protocol before going to prescribe any exercise for the patient. Shoulder labrum. So there is an instability. A lot of people post dislocation, they used to come to us. We are only focusing on the strength. We forget how to actively, okay, reactivate the stability of the shoulder by means of proprioceptive activation exercises. I'm going to show that. So these are all the 12 webinar evidence-based protocol webinars I designed, okay, for your reference. So whoever interested people, you will get the offer by today only. If you are a doer, okay, you can do by today only. Or else if you are a viewer, you can view. But with this free webinar also, I always have this scenario in my mind. That means if we are not serious in our growth, okay, we can't be successful person. So if you want to take any further step, you need to be serious and you need to involve in the complete process. Okay, if you are coming and going, if you are not doing any actions, then within 3 days or 4 days, you will forget this webinar itself. And this will go by like out of 10 things, like a one thing, it will go out of your life. So be serious and take the actions necessarily. Now, continue the webinar. A persistent fiber depolarization. What is meant by persistent fiber depolarization? Whatever the sodium ion which is influxed, because of that there is a depolarization happened in the muscle fiber in the T tubule. Because of that, what is happening? A prolonged calcium channel opened in the sternal cisternae of the muscle fiber. Because of that, that calcium ion excessively going and staying in the cross bridges, okay, and it is getting locked there. So because of that, what is happening? There is a produced palpable taut band at the clinical examination. That means because of that, the muscle is not getting relaxed. You are getting the contracted muscle. That contracted muscle is able to palpated by the therapist while doing the clinical examination, palpation examination. That is the taut band. That is the thing what we are feeling while doing the palpation. Energy crisis, I hope you know the energy crisis. I already explained to you. Because of the sustained contraction, whatever the arterioles, whatever the capillaries, which will get compressed by means of the muscles. Because of that, decreased oxygen and ATP supply. Because of the ATP deficit, it prevents reuptake of the calcium ions to the terminal cisternae. There is no reuptake, calcium ion stays there, so contraction knot is forming. So because of that, there is a chemical release is happening. Increase in the metabolic waste product, that is the increase in the lactate, bradykinin, substance P, that is the main thing for the pain. So these are all sensitize the pain receptors. Because of that, you are getting the flame. So this is followed by the inflammation. So this is the thing which is happening, pa. So you can able to see here an action potential is the neuromuscular junction here. So this is the neuromuscular junction. So this is the T-tubule especially. So in the T-tubule, what is happening? There are excessive of calcium ions which is coming out of this T-tubule and going to the actin. In that actin, there is a layer called tropomyosin. On troponin here it is there. So it is going and attaching to the troponin and it got locked over there and completely this actin and myosin is like having the bridges continuously without doing any rest. Because of that, you are forming the muscle trigger point. That's it. So this is the fee structure I want to let you know. So each and every webinar, 3 days webinar will be there. Each webinar will be like a 500 per webinar, 3 days, I'm telling. So if you're going ahead with 2 webinars, 35% offer will be there. One webinar is like a 500 means 2 webinar 1000, but 35% you will get a 650 rupees. We are having a 6-month membership program. So if you attend any of our paid webinars, followed by the paid webinars, if you are coming and joining, you will get only 2500 rupees. But if you are coming after this pre-webinar, you will get a 3500 rupees. So 40% you will get the discount. So this is the thing. If you are joining followed by this free webinar, it will be 3500, but I will open the special discount also now. So what is the main problem here? Failure of the relaxation. Failure of the relaxation. It is not like continuous contraction. It is failure of the relaxation. Without ATP, myosin actin cross bridges remain locked. Creates localized contracture with high resistance to passive stretch. So because of that, what is happening? If you stretch the muscle, it won't give you the stretch because it is already depolarized. If you stretch also, again it will increase the symptoms. Okay, it may give you a temporary solution, temporary increase in the range, or temporary the thing is like a temporary relief, but still without you are releasing that, you will have a again and again the problem will be continuous. So this explains stiffness and restricted range of motion. Because of that only the range of motion also is getting restricted. Now trigger point formation, final stage. Palpable taut band will be there. And that will be tender because it got sensitized by some kind of inflammatory products. Referred pain also will be there. Because why the referred pain? There is some facial system is there. If you take a pectoralis minor muscle, from the pectoralis minor muscle, you will have a medial biceps muscle, okay, front arm, that is the front forearm muscles, that is the flexor compartment of the forearm muscle. You used to have this referral pain. So likewise, infraspinatus, there is some some separate facial system referral pattern will be there. Upper trapezius separate will be there. Subscapularis will be separate will be there. There are some muscles which is give the separate facial patterns of the pain. Okay, it will mimic like a radiculopathy. So for that reason, we should know what is the myofascial pain syndrome. Now, so trigger points linked to the central sensitization in chronic pain patients. What is meant by central sensitization? Central sensitization means a failure in perception of the pain in the particular area of the muscle. So usually you will, if you have any problem in trigger point, you will have a problem. So your brain will get sense, oh, there is a problem. So it will give you the pain. After some period, if you don't have the problem also, or if your problem severity is less also, your perception ability on the particular muscle will get changed. Okay, you can't able to feel the relief. So that is called central sensitization. Now clinical makers, pain on palpation. So what all the things you will feel whenever you palpate, you will get a twitch response. Whenever you have the trigger point, you have a taut band you can feel, and the patient will have a localized pain, okay, and they will have a pain in the referred button also. These are all the things you can able to see. Now, what is the anatomy of the myofascial system? There are some facial layers, superficial, deep and all is there, which connects the one muscular to another muscular compartment, from hamstring to the calf, okay, from the low back to the hamstring. Like that, there are some facial system which is connect one muscular compartment to the another muscular compartment. Why it is like a continuous layer? To transmit the force easily. So these are all very rich in innervation with the facial sensitivity. So what is meant by facial connectivity at the trigger point? So this is the uh, scenario where you'll have the referred pain I already mentioned. So these are all the facial lines which transmit the strain from one region to another region. Explain distant pain patterns. If you have a trigger point in your suboccipital muscle, you will have a pain in this head region, temple region. So there is a link between the suboccipital muscle to the cranial fascia, like that. Example, trigger in the gastrocnemius may affect the plantar fascia, like that. Now, so this is the unlocking gift session. So I will share you the link for cervical IVDP in the description now. So now only it will open. Okay, now only you need to request for the access, and I will give you the access within tonight. And if you put I'm a good physio 20, whatever the webinar you are attending for us, you will get a 20% discount. And for the myofascial uh, release webinar, what I'm going to do for the day 2, if you do a fast spot registration, you will get a 50% offer. That means that webinar is only 300 rupees. Okay, that is only 300 rupees. And if you register now, you will get 150 rupees per webinar. That's it. So what I will do, I will send you the link. With that, you can just keep everything like dot dot dot. Okay, only your name and your contact details. With that, only the number is needed. That's it. Everything you can keep dot dot dot, and I will give you the QR. If you scan that, you can able to do the payment. So whoever doing the dot dot dot, in that I can able to understand those all are registered for the MFR. So this will save your time also. And 6-month membership program, I told you it is like a post webinar 3,300. But if you register now, so I will give you only 6 minutes. If you register now, spot registration, you can also avail the a post paid webinar amount. That is only a 180 rupees to 150 200 rupees for the 3 days of webinar. It will be like completely quality webinar. I guarantee that. So it will be open now. So you can I will be sharing the link and everything. So you can do the process. With that time, I don't want to waste your time. I'm going to show you the cervical IVDP assessment video. Okay. In the screen. Meanwhile. So first, let me share you the links and all. So one by one, I will do now. First, I am sharing you the gift. So you can just touch that. You will be notified that access no request given. So one time you do that. And this is for the membership. The second one is for membership. And for the paid MFR webinar, this is for the paid MFR webinar. So I'm going to unmute you now. If you have any doubt also, you can ask me. If you have any doubt regarding registration as well as regarding this topic, okay? And my small request for you, so just go to the link and comment your top 3 takeaways from today's class here. So I'll be so much happy if you do this. I will be sharing this QR also to you. You can finish your payment process who are looking for the membership program or a paid webinar. Okay, you can do that. Meanwhile, I'm going to share you the assessment for the cervical IVDP. Is there any doubt, my dear students? Thank you so much for your support. Thank you so much for your patience in listening. And today, Saturday night, tomorrow, Sunday. So a lot of people used to do a lot of stuffs by destroying themselves or something. But you came here and showed up and you are doing a better job towards your career. Okay. It is like really appreciable. So your video is playing now. For the cervical radiculopathy. So first we will start with the on ROM, okay, range of motion assessment. So range of motion assessment, patient should be in the relaxed sitting position. So tell the patient they should not use their shoulder or else the thoracic spine to compensate for the head movement. Okay, you need to see the quality also. So start with the flexion as much as possible. So you can use your 2 fingers. So between the sternum and the mandible. So if it is touching, that is like normal. If it is restricted, then you need to find that is because of the joint or else or because of the myofascial tightness. The back side, it should be like a 45-degree. The nose has to go towards the ceiling. If the tip of the nose is going towards the ceiling, then you can consider this as a normal range. Yes. Now rotation, side to side rotation. So side to side rotation, this is like a clavicle, right? So it should be near to the clavicle. 45, it is like a usual is more than 60-degree. If it is like a less than 60-degree, then we can consider like it is like a restricted. Side to side bending. Side to side bending is a 45-degree on each side. So it should be like you need to draw imaginary line like vertical and the transverse. So between that, if it goes more than that, it's a normal. Okay, now there is a way to check whether this restriction is because of the myofascial or else because of the joint capsular pathology. So I will teach you the technique now. So whatever the range, especially the rotation and side flexion, if they showed less in the range of motion, we need to ask the patient to lift the shoulder and repeat it again. If the symptoms are less or if the range of motion is increasing, it's because of the myofascial tightness. Okay, So the thing is, you need to elevate the shoulder, thereby you are relieving the tension from the upper trapezius muscle especially. So with that, you can able to differentiate between this is because of the joint pathology or muscle or else both. Okay, so this is the range of motion. So in the range of motion, if the patient is having a cervical radiculopathy, the extension will be limited, the rotation will be limited, and most of the patient, all the range of motion will be limited, but extension and rotation will be the most reduced joint, most affected joint positions, because that is directly involving in the foraminal compressing. So if you do extension, what is happening? Intervertebral foramen is getting compressed, thereby the symptom will get provoked. And with rotation also, if you are rotating towards the same side, again the same thing will happen. And for the side flexion also, the thing is same. You are compressing the intervertebral foramen. So this is the assessment on like range of motion. So here, if the patient you are suspecting while doing the range of motion assessment, if they are getting any radicular symptoms, we need not. You have 3 more minutes to register for the paid webinar as well as for the MFR and membership. To go ahead with the passive range of motion, because already the range of motion is restricted, or else you can go ahead with the passive range of motion. If they are telling like any pain or discomfort while doing some movement, you can tell the patient to do the flexion. Okay, so with that, what you can do, you can just do the infill assessment, either it is because of the tissue stretch or else any spasm is restricting. Like that, a gentle overpressure you can give for the all movement. Always you compare with the opposite side, then you can go ahead with the same side. Okay, so every moment you can do, and you need to feel the end feel at the end range how it is feeling. That is called end feel. Usually it should be a tissue stretch. If it is abnormal, it may be a spasmodic or else a empty end feel, or patient won't allow you to press. So that might be the common features in the cervical radiculopathy. Yeah. Now we will see the neurological assessment and neurodynamic assessment for the cervical radiculopathy one by one. First we will finish the neurological assessment. So for the neurological assessment, what we need to see? We need to see the myotome and we need to see the dermatome. So for the dermatome, there are C5, C6, C7, C8, T1. So C5 always you can check in the deltoid region. Okay, tell the patient to close their eyes. Okay, always you can check with the opposite side. So you need to instruct the patient, now I am going to touch some part. Okay, you need to differentiate whether it is a right or left, and you need to tell the location exactly where it is, and you need to tell the kind of sensation, whether it is a touch or else any pricking kind of sensation. So we can use any pin, or else we can along with that we can use any hand, or else you can use any pen in that nib is pricking and backside of the pen is touching. Like that also you can use. Which side?
Right side.
So like that. So location with side. That is for C5. C6, you can keep your hand like this. Yeah, keep it down. Dorsal surface of the thumb for the C6. Okay, dorsal surface. And for the C7, dorsal surface of the middle finger. And for the C8, dorsal surface of the little finger. And the T1, ulnar aspect of the forearm, which is proximal to the wrist. Okay, this part. So these are all the dermatomal sensation checking. This is as per the American Spinal Cord Injury Association guidelines. Okay, yeah. Now you can lie down. Okay. I hope you got some insights from the last webinar, that recording also. So my dear students, if you are still having any problem with recording or something, you can ask me, or else if you have any doubt regarding the disk like trigger point also, you can ask. Do you have any doubt?
No, sir.
Who is that? Dr. Aishwarya?
Sir.
Okay. So these are all the facial lines we are going to see in the paid webinar. Superficial backline, front line, lateral line, spiral line. So that is a functional line. And deep front line, arm lines, and there are some oblique lines, and there are, yeah, that's it about the lines. So along with this insight, there are a lot of things I'm going to add with that. So what is the key takeaways from the today class? So can anybody let me know what is meant by the trigger point after attending this class? Can anybody? What is trigger point? Which dysfunction it is? It is a myofascial dysfunction, especially which part is having the dysfunction?
Neuromuscular junction dysfunction.
Yes, especially. So if you know that, I will be happy. If you're taking that one takeaway, I will be happy. You just touch the install link and just to type it is a neuromuscular junction dysfunction. Okay. And the thing what you need to remember is the first thing, it is a neuromuscular junction dysfunction, okay, which is the main thing which forms the muscle knot. And one more thing, why it is involving excessive acetylcholine release. Because of that, muscle is getting persistent depolarization. Because of that, there is a ischemia, okay, followed by that, that is creating the energy crisis in the muscle. So because of that, the muscle is not getting relaxed by itself. So the pain which is sensed by the nociceptors because of the production of what? What all the chemical substance I told you? Any one if you tell, I will be happy. What are the chemical substance? Metabolic chemical substance, mediators of the inflammation and all. Chemical mediators of the inflammation and metabolic waste in the muscle. I told you, right? There are some 3 to 4. Any one? Can anybody?
Metabolic waste lactate.
Very good.
In- increased acetylcholine in the
Yeah, that
muscle.
is not. Yeah, that is not in the muscle actually. That is there in the receptors. That is there between the neuromuscular junction. Here you can have a bradykinin, prostaglandin, P substance. These are all the inflammatory mediators you will get. This is the thing which is sensed by the nociceptors and which gives you the pain in both local as well as referred. Okay, if the upper trapezius is connected, you will have a lateral arm pain or else you have a headache. Usually you have a headache. So neck pain or else headache will come because of the upper trapezius. If you press that particular knot, you will have a radiation pain to the neck and head. People used to complain this. But that is through the fascia it is happening. And followed by that central sensitization, I already told. I will explain in detail in the pain webinar. What is meant by central sensitization? What is the particular structure in the brain which is causing that? Now, diagnosis by means of palpation, reproduction of the pain and referred pain and all. These are all the things you need to see. And local twitch response also you need to see, LTR. So evidences supports the multimodal approach. What you need to do that we will see in the pain webinar. And integrated facial anatomy, we should know that also we will see in that. And what is the modern clinical reasoning framework? That is also we will see in the pain webinar. Ultimately, successful management requires combining science, palpation skills, and individuals. Exercise prescription is the main thing. Individualized exercise prescription. Okay, whatever the thing you are doing, if you are not giving individualized exercise prescription, you can't able to come out of this problem. That's it. So thank you so much, my dear students. If you have any doubt, you can ask me. So we will discuss the question and answer now. Is there any doubt?
No, sir.
No doubt. I hope how many of you still now? There are 20 people are here. Thank you, Dr. Sahil. So are you happy with this pre-webinar? Are you thinking that this is for some marketing purpose? Did you get any information usefully tonight?
Yes, sir. Very informative information, sir.
Thank you. Thank you so much for that. Today I'm getting a lot of nose block. That's why I couldn't able to give a smile also. Okay then. Good night. Happy Sunday tomorrow. See you in the next webinar. Okay. If you have anybody problem with uh, joining in the membership or something? Is there anybody? 2 more minutes to finish your registration, dear student. So me only. Okay then. Nobody is having. Is there anybody who is having any problem with registration? Rest of the people can go. Is there anybody who want to speak related to this registration? Anybody, my dear students? Else can we close the session?
Yes, sir.
Okay, pa. Bye. See you. Good night.